Welcome back to the Talking Ketamine podcast. This is episode 65, Ketamine and Buprenorphine.
What if we could make ketamine's positive effects last longer? This study explores whether a low dose of buprenorphine given after ketamine can help sustain its benefits for people with suicidal thoughts.
So if you are joining us today, you are probably already familiar with the incredibly fast-acting relief that ketamine can provide for severe depression.
Right. It's pretty well known at this point.
Yeah, exactly. But today, we are looking closely at a brand new, randomized, double-blind, placebo-controlled trial. It was just published in the American Journal of Psychiatry.
Led by Dr. Jason Tucciarone and his colleagues at Stanford.
Right.
Back in May of 2026.
That's the one. And the mission for our discussion today is to really explore a fascinating and, frankly, potentially life-saving pharmacological strategy.
Because it's designed to extend that rapid but notoriously fleeting relief provided to individuals who are battling major depressive disorder and active suicidal ideation.
Which is so critical, because this premise really targets the single biggest frustration in modern psychiatric treatment right now.
Oh, absolutely. I mean, when someone is experiencing active, intense suicidal ideation, waiting weeks for a conventional medication to build up in their system that is simply not an option.
Right. It's a severe medical emergency.
Exactly. And ketamine changed that landscape entirely because it acts within hours. It initiates this rapid cascade of neural communication.
Primarily by interacting with the NMDA receptors in the brain, right?
Yes, and that essentially pulls patients back from the absolute brink. It's an immediate intervention.
But the problem, and really what the Stanford study is directly addressing, is the fade.
The fade is the hardest part.
It really is. That initial rapid relief is completely transient. For a lot of patients, the profound relief they feel on day one, it starts to evaporate within a few days or maybe a week.
Yeah, because the new synaptic connections are incredibly fragile at that stage. They prune away very quickly.
Right. So can you explain what's actually happening in the brain there?
Sure. So the ketamine creates a massive burst of glutamate, which is the brain's main excitatory neurotransmitter. It's essentially the brain's accelerator.
Okay, the accelerator.
Right. When someone is severely depressed, those glutamatergic pathways often become really sluggish or stuck. Ketamine floods the system, forcing new pathways to open up.
But they don't stay open.
Exactly. Without constant structural support, the brain just reverts to its established depressed baseline.
Okay, so here's a question you might be wondering. If ketamine works so incredibly well and so fast, why is the short duration such a crisis? Why can't we just prescribe a steady, ongoing regimen of ketamine infusions for you if you're struggling?
It seems like the obvious solution, right? Just keep giving the ketamine.
Yeah, I mean, why not?
Well, the practical and biological dangers of continuous high-frequency infusions are enormous. First off, there was a distinct lack of comprehensive long-term safety data for years of continuous use.
You just don't know what it does over a decade.
We don't. But more immediately, frequent exposure carries severe risks of bladder toxicity. Yeah, specifically a highly painful condition called interstitial cystitis. And you also have to consider cognitive dulling and cumulative dissociative effects. I mean, you are repeatedly administering a potent anesthetic.
Not to mention the logistics of all that.
The logistics are a nightmare.
You have to physically go into a clinic, undergo the infusion, and arrange transportation home because obviously you can't drive.
Right. And the financial burden is heavy. It's often entirely out of pocket, and it just disrupts your entire life.
So researchers have spent years trying to find a bridge medication to solve this.
Right? They have. They tried drugs like lamotrigine or lithium to stretch out the benefits.
But those previous attempts largely failed.
They failed because they were mostly trying to target the exact same glutamatergic pathways that ketamine initially acts on.
They were just trying to force the accelerator to stay down.
Exactly. But biology doesn't work that way. The brain builds tolerance. The brilliance of this new Stanford study is that they realized repeating ketamine endlessly or hammering that same glutamate system, it just isn't a sustainable long-term answer.
So they had to look somewhere else.
They decided to look for an entirely different biological pathway to extend the relief.
And this is where we pivot to buprenorphine. Because for a long time, the prevailing wisdom was that ketamine worked almost entirely through that glutamate system you mentioned.
But recent neurobiological evidence suggests ketamine's effects might actually rely heavily on a completely different network.
The brain's mu-opioid receptor pathways.
Yes. The mu-opioid system is essentially the brain's internal pain relief and reward architecture. And for years, scientists noticed a really peculiar phenomenon regarding this.
What was that?
If you give a patient an opioid blocker, a drug like naltrexone, right before giving them ketamine, the ketamine's antidepressant effects are significantly blocked.
Wow, which is a massive clue.
It's a huge clue.
I mean, if blocking the opioid receptors stops ketamine from working, it means the opioid system is mechanically necessary for ketamine's magic to happen. It's not just a glutamate story.
Exactly. It proves that ketamine relies on an opioid pathway trigger to solidify its effects. So researchers theorize something new.
That instead of hammering the glutamate system after an infusion, you might be able to sustain the relief by gently stimulating that mu-opioid pathway.
Right. And buprenorphine is highly unique in how it interacts with that pathway. It is what we call a partial mu-opioid agonist.
We should explain what partial actually means mechanically there, because it completely changes the safety profile.
It absolutely does.
If you picture a cellular receptor like a light switch on the wall, a full agonist like, say, morphine or oxycodone flips that switch all the way up to 100%.
Right. A total activation.
Yeah, which gives you maximum pain relief, but it also brings maximum risk for dangerous side effects, like your breathing slowing down to a halt.
But a partial agonist behaves differently. Buprenorphine binds to that receptor very tightly. In fact, it has an incredibly high affinity for the receptor.
Meaning it will actually knock other opioids out of the way to get there.
Exactly. But once it binds, it only flips the switch up to about 30 or 40%. It has a built-in ceiling effect.
So it stimulates the specific pathway that ketamine seems to utilize, but it structurally cannot trigger the severe, life-threatening respiratory depression associated with full opioids.
Right, it puts a hard cap on the activation.
Which makes it a uniquely compelling candidate for outpatient psychiatry. So let's talk about the trial itself. The Stanford researchers designed a really meticulous trial to test this theory.
They gathered 50 outpatients, all adults with major depressive disorder who were currently enduring a major depressive episode.
And to truly understand the weight of this study, you have to look at the severity of the participants. Do you know what the average length of their current depressive episode was?
It was over 119 months.
That is essentially 10 years of continuous, unbroken depression for the average participant.
It's staggering.
That isn't just a fleeting chemical imbalance. We are talking about a brain that has fundamentally wired itself around hopelessness for a decade.
Yeah, the neuroplasticity of these patients was rigidly set in despair. And crucially, they all had to present with clinically significant suicidal ideation.
Right, and that was verified by scoring a 6 or higher on the scale for suicide ideation, or the SSI.
Now, the SSI is a highly specific clinical tool. It doesn't just ask if you are sad.
It measures the intensity, frequency, and specificity of suicidal thoughts.
Exactly. A score of 6 is the widely accepted threshold indicating that a patient is at an active, high risk and requires immediate medical intervention.
These individuals had real documented treatment resistance. They had failed multiple standard antidepressant therapies over those 10 years.
So the protocol for the study went like this. Every single participant received a single open-label IV ketamine infusion at a standard dose.
That was 0.5 milligrams per kilogram over 40 minutes.
Right. Then the researcher sent them home and waited exactly 48 hours before doing anything else.
Okay, that 48-hour window is arguably one of the most important structural decisions in the entire trial design.
Oh, without a doubt. When you introduce intravenous ketamine, you are creating a biological storm in the brain.
A storm. I like that.
The acute affects the dissociation, the massive glutamate surge, the immediate shock to the nervous system. They are highly disruptive.
So you can't introduce a second experimental variable while the storm is still raging.
Precisely. You have to wait for the storm to clear to see what new neural structures actually survived. By waiting 48 hours, researchers could measure the true baseline drop in suicidal ideation caused by the ketamine alone.
It confirms that the patient actually responded to the infusion in the first place.
Exactly. And furthermore, it establishes a critical safety buffer when transitioning a patient from one powerful mechanism to another. It proves that this sequence is safe for a real-world clinic to execute.
So once that 48-hour mark passed, they randomized the patients. Half were given a low daily dose of sublingual buprenorphine, which is a small lozenge you dissolve under your tongue.
And the other half received an identical placebo lozenge. They continued this daily regimen at home for 4 weeks.
Think of this treatment approach like gardening. You are planting a seed of rapid relief with the ketamine infusion, and then you are fertilizing the soil with the daily buprenorphine to help that relief grow and last longer.
If we push that gardening metaphor a bit further, it explains the mechanics perfectly. The buprenorphine isn't just generic fertilizer.
Oh, what is this then?
It is acting almost like a trellis for the mu-opioid system. The ketamine violently breaks the hard, depressed ground and initiates this sudden burst of fragile neural growth.
Right.
But without ongoing structural support, the trellis, that new growth, is going to collapse under its own weight as soon as the ketamine wears off.
That makes so much sense. And testing this entire process in an outpatient setting is a massive leap forward.
It really is. A previous study looking at buprenorphine heavily featured inpatients, people who were hospitalized, highly controlled, and closely monitored around the clock.
But by proving this trellis effect works in an outpatient setting where you take your dissolving medication in your own kitchen, it proves this is a scalable solution.
Exactly. It's a protocol a regular psychiatric clinic could realistically prescribe to you or your loved ones without requiring a hospital bed.
The accessibility factor cannot be overstated. So after sending these patients home with their respective lozenges, the researchers carefully tracked their scores over the course of 4 weeks.
And the final data is undeniably striking. The buprenorphine significantly enhanced and sustained the anti-suicidal effects of the initial ketamine infusion.
Let's look at the numbers. On the SSI, that scale for suicide ideation, where a 6 represents active crisis, the group taking the daily buprenorphine saw their scores drop by an average of 11.6 points from their original baseline.
That's huge. Compare that to the placebo group, who only saw a 6.3-point drop.
Right. An 11.6-point reduction is a seismic shift in a patient's reality.
You are taking individuals who were in acute, life-threatening psychological distress, trapped in a 10-year cycle of despair, and bringing them down into a vastly safer, more stable psychological space.
And the response rates at the end of the 4-week trial paint an even clearer picture of the trajectory.
By day 31, 78% of the people in the buprenorphine group maintained a positive response, meaning their suicidal ideation was cut in half or more.
78%, that's incredible.
In the placebo group, it was only 48%, and the placebo group actually started to see their suicidal thoughts slowly worsening again as the weeks went on.
Which mirrors the traditional ketamine fade we talked about earlier.
Exactly, but the buprenorphine group remained stabilized.
However, this is exactly where the data presents a massive clinical plot twist.
Yeah, this is the most fascinating part of the study for me. Alongside tracking suicidal thoughts, the researchers were also tracking overall general depression.
Using 2 standard comprehensive scales, right? The MADRS, which is the Montgomery-Åsberg Depression Rating Scale, and the AMD, the Hamilton Depression Rating Scale.
Right. These scales measure the broader, heavy symptoms of a depressive episode.
Things like your sleep quality, your appetite, your physical energy levels, and your general capacity to feel joy.
And while the general depression scores went down for both groups over the course of the month, the data showed absolutely no statistically significant difference between the buprenorphine group and the placebo group when it came to overall depression.
Wait, let's unpack that. How is it possible that the buprenorphine group was significantly less suicidal, but not significantly less depressed? Aren't those 2 things inherently tied together?
In standard psychiatric practice, we generally assume they are identical. We view suicidal ideation merely as the ultimate, most severe symptom of depression.
Like, as the depression worsens, the ideation appears, and as the depression lifts, the ideation fades.
Exactly. But this specific divergence in the data suggests something far more complex about how the brain processes suffering.
It suggests they are operating on overlapping but ultimately separate neurobiological circuits.
You hit the nail on the head. The clinical theory emerging from these findings is that suicidal ideation might not just be extra severe depression.
Right.
It appears to be a distinct phenomenon characterized specifically by unbearable psychological pain, a profound sense of hopelessness, and an overwhelming primal drive to escape that pain.
And that specific drive to escape the psychological pain itself is what the mu-opioid system regulates.
Yes. We know the opioid system manages physical pain, but this implies it is equally responsible for managing profound emotional agony.
Wow. So the ketamine, followed by the buprenorphine locking into those mu-opioid receptors, appears to specifically target that pain and escape circuitry.
Precisely. The buprenorphine effectively extinguishes the immediate burning crisis of wanting to die by turning down the brain's internal pain dial.
But the general depression, the heavy limbs, the disrupted sleep, the complete inability to feel joy or motivation, that broader anhedonia is running on a different track entirely.
Right. That low mood and lack of energy is likely driven much more heavily by serotonin, dopamine, or neuroinflammatory pathways.
And buprenorphine doesn't resolve those pathways.
No, it doesn't. So what you end up with is a patient who is still undeniably depressed, still struggling to find energy or joy in their daily life, but they are no longer in acute danger of taking their own life.
If this distinction holds true in brighter medicine, it completely changes how we approach triage and psychiatric diagnosis.
It really does.
Yeah.
I mean, if a patient presents in the emergency room with active suicidal ideation, treating them with a serotonin-based medication might be targeting the wrong circuit entirely for the immediate crisis.
It forces the medical community to recognize that stopping the desire to die and restoring the desire to live might require two completely different biological tools.
That's a great way to put it. Two different tools entirely.
Now, the efficacy data regarding the suicidal ideation is highly promising, but whenever we talk about introducing any drug that interacts with the opioid system, we have to require a rigorous look at the safety profile.
Absolutely. Safety is paramount here.
Buprenorphine works on opioid pathways. If you're a patient looking at this data, aren't you trading the risks of repeated ketamine for the risks of an opioid? What happens at week 5 or week 10?
It is the single most critical question for any clinician looking at this protocol. And the answer hinges entirely on the meticulous dosage parameters of this study.
Because they kept the dose very low.
Extremely low. The maximum dose allowed for any patient in this trial was zero point 0.8 milligrams a day.
To understand how small that is, we need to compare it to how buprenorphine is traditionally used.
Right. When prescribed for severe opioid addiction or intense chronic physical pain, the starting dosages are massively higher.
Yeah.
Clinicians are prescribing 8 milligrams, 16 milligrams, and sometimes up to 24 milligrams a day.
Wow. Okay, so a dose of 0.8 milligrams is just a tiny fraction of a standard prescription.
It is intentionally designed as an ultra-low dose. By keeping the dosage under 1 milligram, the risk of a patient developing a profound physical dependency or experiencing severe, debilitating withdrawal is drastically minimized.
But even at an ultra-low dose, there were distinct side effects reported during the 4 weeks, right? And they were notably higher in the active buprenorphine group.
There were. The most common issue was dizziness. That was reported by 21.7% of the patients taking the active drug, compared to absolutely zero in the placebo group.
Which makes perfect physiological sense when you are engaging the opioid receptors.
It does. Opioid interaction frequently causes vestibular disruption. It interferes with the inner ear and the complex system that manages your spatial orientation and balance.
And if you are taking this medication at home, navigating that dizziness is a very real physical factor you have to manage.
Definitely. It's something patients need to be warned about.
Patients also reported oral burning directly from the dissolving lozenge. About 17.4% experienced that discomfort. And nausea was reported by 13% of the active group, again compared to zero on the placebo side.
Those physical side effects are significant, but the vital context that must be communicated is the severity level. Throughout the entire trial, there were absolutely no serious treatment-related adverse events.
So no instances of life-threatening respiratory depression.
None. And no hospitalizations caused by the medication itself.
To further validate the safety of this ultra-low dose, the researchers didn't just end the trial at 4 weeks and assume everything was fine.
Right, they required the participants to stop all medication.
And then they monitored them closely for 2 additional weeks, checking in on days 38 and 45 specifically to watch for physical withdrawal.
They utilized 2 strict tracking systems for this. The Clinical Opiate Withdrawal Scale, known as COWS.
And the Subjective Opiate Withdrawal Scale, or SOWS.
Exactly. These scales track specific physical symptoms of dependency, measuring resting heart rate, sweating, tremors, bone and joint ache, and gastrointestinal distress.
And across the board, during those 2 weeks completely off the buprenorphine, the withdrawal scores were categorized by the researchers as minimal to none.
Which is incredibly reassuring data for anyone worried about the dependency risks of a 1-month bridge protocol.
But interestingly, they did notice a slight, measurable uptick in the suicidal ideation and depression scores after the patients stopped taking the buprenorphine.
They did. It wasn't a massive, dangerous crash back to their baseline, but rather a mild worsening of symptoms.
Which, clinically speaking, serves to prove that the drug was indeed doing the heavy lifting during those 4 weeks.
Exactly. When you remove the trellis, the new growth struggles to support itself.
But your earlier caution about week 10 is absolutely warranted.
It is. We simply do not have the clinical data yet to show what a 6-month or 12-month buprenorphine bridge looks like for depression.
Furthermore, the researchers strictly excluded any patients with a recent history of substance use disorders from participating in this trial.
That exclusion is a massive caveat. If a patient has a history of opioid use disorder, introducing any mu-opioid agonist, even a partial one at an ultra-low dose, carries a vastly different risk-benefit calculus.
Clinicians have to screen their patients incredibly carefully.
They do. But for the specific population studied here, individuals locked in treatment-resistant depression with acute, life-threatening suicidal ideation. This study represents a cautious, rigorously tested, and profoundly hopeful step toward a scalable therapeutic option.
It really does. It provides a mechanism to lock in the relief of ketamine without requiring a patient to center their entire existence around an IV clinic.
Exactly.
As you process all of this data, it leaves you with a deeply provocative thought about the nature of human suffering.
Yeah.
If this study definitively proves that we can successfully treat suicidal ideation without simultaneously curing the underlying depression, it forces us to ask, have we been looking at the biological root of mental anguish all wrong? What if the intense desire to escape pain is an entirely separate biological switch in the brain, just waiting for the right key to turn it off?
It challenges the very architecture of how we understand and treat despair.
This research offers some exciting potential for those who have found relief in ketamine and want to see their improvement sustained.
This study suggests a potential avenue for extending the therapeutic window following ketamine, and clinicians should be aware of buprenorphine's effect.
A little bit of hope can go a long way. Thanks for listening to the Talking Ketamine podcast. We'll catch you on the next one.